Last for this portion, I'm going to review LV function. And I know this is a little bit tedious and long. At the same time, you need to have a framework to eventually work on it in the afternoon. So this is why we have to do this before you take your probe and start having fun. So this is the painful part, but you need to do this. So talking about EF, I think one of the major pieces of information we want to know when we're using the ultrasound is to determine how the heart is working. And we do this by measuring EF as a way to assess systolic function of the heart. Okay? One of the things that you have to understand is you're looking for two major things. How the walls are moving, they're moving in or out, they're moving a lot or little, and whether the walls are thickening. You know, a normal myocardium will move inward during systole and also will thicken. So that's important to not just seeing the movement, but also the behavior of the muscle as it contracts. Okay? Again, EF has to be a simple parameter. It should be something that can be reproducible. Everyone should be able to get numbers that basically match with each other. Again, it's a parameter that gives you a global contraction of the heart, even though there may be areas that don't move that well. And it's going to be giving, again, as a black box. This is a number, EF of 52. That doesn't mean that the heart is completely perfect. You may have a septal wall that doesn't move too much, but the global EF is still okay. So again, take that into consideration when you get an EF number. Normal is bigger, higher than 55. Anything below that is reduced. When you get EFs below 30%, it's severely reduced. And you may have scenarios on the other way around. If it's too high, there's a problem. Either you're very empty or you're hyperdynamic. And again, you should be able to assess this visually and get a very good estimate of the EF just by looking at your images. And that's why the inter-observer variability, when you have a little bit of experience, it's actually not that bad. This has been validated that people looking at the images can say where the EF is just by looking at it. And you'll see it. It's kind of funny. I do this experiment, I do this exercise with my residents. When they give you the EF, when they give you an echo report, you will see that they will measure some of this information, and they'll give you by, I don't know, Takel's method. I'm going to show you in a minute how that's done. They give you a number. Then at the end, because the funny thing is that when you guys or you residents do an echo, look at an echo report, what's the first thing that you do? And I can cut my right hand if you don't do that. You go to the end of the report and you read the summary of the report. That's it. You don't care about the other stuff. If you happen to pay attention, the EF done by some of these methods is different than the EF reported at the end of the report. I don't know if you've noticed. Okay, nobody does this, but if you pay attention, you'll see it. The EF from the by Takel's method will be, I don't know, 38%. Then at the end of the summary thing, which is the only thing you really care about, it will tell you EF is 50%. You say, but they measured here, whatever. So they're basically eyeballing the whole EF, understanding that some of these ways to measure things, which I'll show you in a minute, may not be completely accurate as a global representation of EF. So again, it has to be accurate, quick, reproducible, simple. And again, it should be independent of the ventricular geometry. So the three major methods, and there are other things we can talk about, but the ones I want to concentrate for the sake of a surface echo will be the M mode or the Takel's method, okay? It's not uncommon that when they give you the EF, they put in parentheses a little thing like take or take hold, and usually this is just to let you know which technique they use. You can use a method of discs. It's also called the Simpson's method, or you can basically eyeball it, which is an objective way. Okay? And mode or the Takel's method. You're going to go into a parasternal short or long axis. It can be done in either of the parasternal views. Okay? And ideally, it's better when you don't have major regional wall motion abnormalities in those things. And you're going to shine your light. You're going to do an M mode, trying to get the septum and get in the posterior wall. Okay? Again, it's a unidimensional measurement. And that's why it's so important, because if you have a posterior wall that doesn't work, the EF is going to be terrible, even though the heart may have a decent EF. That's why you have to understand that a Takel's method is measuring particular segments of a wall in a unidimensional way. So the whole idea is that you measure a diastolic diameter and a systolic diameter. And when you apply your M mode, it allows you to really very easily see that. This is the ventricular cavity in diastole. This is a ventricular cavity in systole. And you generate a ratio of the diastolic minus systolic over the diastolic, which is going to be your fractional shortening. Okay? And the fractional shortening is a number that is not an EF. Okay? It is fractional shortening. Because of the geometrical characteristics of the heart, mathematically you can prove that that certain diameter change correlates with a volume change. And I'm not going to bore you with equations, but the simple thing to do is that if you multiply your fractional shortening by 2, you get your EF. So if the fractional shortening is 20-something%, don't freak out like, oh, 20, no, that's not the EF, that's a fractional shortening. If it's 20%, that means the EF is 40. Okay, just pay attention to that, because the machine will give you this automatically if you're using the software that comes with the machine. But if you're doing just fractional shortening alone, beware that this is what good numbers are. Okay, and that's completely normal. And this is somebody doing the method. You see a short axis parasternal view here. You see your diastole and your systole in an M mode. You freeze the image. Then with your caliper, you move it, and then you start measuring things. In this video, they're using a particular software that you need to fill up certain things. If you pay attention, this is part of the free RV wall. This is the RV cavity. This is the interventricular septum. This is the LV, and this is the posterior wall. This thing that you have in between here, this is papillary muscle contamination. This is this, okay, going in and out. Again, you will get better when you do this, and the machine starts giving you all these numbers, okay? Again, don't freak out, because the software needs you to do it in a particular sequence, so the machine then gives you a report. We're not interested in that, so you don't have to do that. But if you're willing to go through their software, whatever, it's actually very cool, because the machine will give you all these things as part of the report. And normally what we do is this diastolic minus systolic diameters. And then you get your EF in this case, and you see how it puts in parentheses takeoffs, so then you know what they're doing. Okay, the fractional shortening is 41%, their EF is 71%. Again, takes just a couple of minutes to do this. The method of discs is a little bit different, because now you're going to work in 2D. Instead of a unidimensional mode, you're going to do in a 2 mode. And you're going to get it preferentially in a 4-chamber view, which you already have seen. We can do it in the apical views. Or you can actually tilt the probe 90 degrees and get a 2-chamber view. And ideally, because now you're doing 2 measurements on 90 degrees to each other, you should be able to capture if there's any major wall motion abnormality, and it may be a better representation of what's going on. And the idea is you create little discs, you calculate the volume of those discs, and you add them up. The machine will do this for you. And I'm going to show you how that's done. You basically trace the endocardium from the hinges of the mitral valve all the way to the apex, and you get a 4-chamber assessment here and a 2-chamber assessment. Using this beautiful equation, you determine the volume of the ventricle. So you trace your endocardium, and each machine has different softwares to do this. They vary a little bit. If you want this afternoon, we might be able to play a little bit with this. So you do this in diastole. You do this in systole, and then you get diastolic volume minus systolic volume over diastolic volume. EF, this gives you an EF. Okay? And it's better. And theoretically, you should be able to then get the EF in a 4-chamber view, get an EF in 2-chamber view, and basically average those two. If you do that, at least you're taking into account different walls. And this is how you do it. You freeze your image, you go into a diastolic frame, you move your trackball until you get what you think is best. Then with your caliper, you put it on the hinges of the mitral valve, you drag the cursor all the way to the apex, You can then modify a little bit the edges, the endocardial edges, okay? And it gets you a volume. Then you move it now into your systolic frame and do the same thing. You put it on the hinges, you drop your to the apex, and look at what you're getting here. The EF is being generated in front of your eyes as we speak. And this takes 20 seconds. Okay? This is how it's done. Again, it gets, for one, you need to understand how they obtain the EF, how the cardiologist uses this, how can you be even more quantitative. I think when you move to the point where you're looking at the image and you get a subjective assessment of the EF, it's actually very elegant if you start getting some of this stuff like numbers, okay? And it takes very little trouble. Again, if you eyeball the EF, the correlation is there. It's been clearly shown. There are many studies showing this, so it's a reasonable way to do it. And you can see it here. If you look at this image, and it's a matter of getting accustomed to this, you can say that this heart is contracting well. You can even say, if you get very picky, this might be hyperdynamic actually. I think this guy might be a little bit dry. Again, that's when the subjective part starts playing a role here. If the patient is normotensive and stable otherwise, I look at this, I say, it's a young kid, good heart, no big deal. If the patient is struggling with pressure, and then this patient may need a little bit of blood. And that's when the clinical context plays a big role. But if you see a heart like this should be obvious to you. There's a problem here, okay? And you don't have to be very fancy to just pick it up. If you see the image from before, now you see this image, we got a problem here. And this is what we're trying to do. We're trying to basically allow you to pick up major problems. Look at this one here. This is truly empty. We have what we call the kissing sign. The papillary muscles are touching each other. That means you're either very empty, or it could mean you're very vasodilated. When you have a low tone state, the end systolic volume goes very low. So that can be also the problem. So if you're hypovolemic, that's your clinical impression, you solve this with fluids. If you're hyperdynamic, you might give a little bit of fluids, but what you need is basically tone to improve this. So again, because we're looking at different walls in the heart, you can then have an idea of which coronary can be affecting the perfusion of the heart, and you can make a diagnosis of a problem. And again, different areas of the heart are basically irrigated by different coronaries, and then you can establish, depending on the view, which coronary can be affected. And if you look at your short axis parasternal view, this is your circumflex, this is your right coronary, and this is your LAD that is including the septal wall, the anterior wall. Okay? Again, sometimes it's very obvious. You do an echo and you see the posterior wall going down. And then you have an EKG that suggests that you have ST segment elevations, let's say on V1 and V2. And then you start thinking, oh, this can be an inferior posterior MI. Let me do right-sided leads. And again, this is the type of things that will allow you to improve and make your diagnosis better, if you ask me. And again, it's very obvious. If you have someone that didn't have a wall motion abnormality before, and now you come in and you see something like this, where this wall here is barely moving. Just pay attention. The movement, the heart vibrates a little bit, but also this wall is not thickening at all. You see how this wall is moving in and thickening a little bit? Here you don't have that. By the way, this is the mitral valve. This is one of the extended views. Okay? And again, there's a funky movement here between the septum, and you can start asking me, well, what's the right-sided pressure? I'm not going to go into those details. But again, you should be able to pick up this. And if you do an echo and you see something like this, you got a problem. And as I tell my residents, if you can pick up a problem, that's all I want from you. If you're going to pick up a phone and call me. You may not have the complete diagnosis, but if you recognize there's a problem, that's 90% of the issue. So just a couple of words on volume status, which also goes with LV function. That's why we do the IVC interrogation. So it's a costal view. When you modify, you go into IVC, allows you to measure the diameter, and the diameter responds to the breathing of the patient. Okay? And again, just to remember, you put your probe on the subxiphoid area, you tilt the marker towards the ceiling, and you aim towards the liver. That's how you get that view. and you get your liver, and you get the IVC. Again, pay attention. The IVC has to drain into the right atrium, okay? Because you can confuse it. And I think I have an image where, look at this image here. This is a liver, you have this vessel here. But this is not entering. You cannot, you have to move it a little bit until it becomes clear. And this usually pulsates. You can see the thing, boom, boom, boom. You may have a severe TR, and the IVC can pulsate too. Again, clinical context, okay? That will give you a good idea of the severity of TR. If you have a pulsating IVC with a reversal of flow in systole, that's a beautiful diagnosis. You have severe TR. That's when you tell your surgeon, you know what? You need to put a ring on the tricuspid valve. Oh, I wasn't planning on doing that. But you have to. This patient is going to do poorly. I'm almost certain Pushbet does that with the surgeons here when she sees that. Again, be careful. Try to differentiate the two. The aorta is thick, pulsates. The IVC is thin and tends to change with breathing. So I'm going to give you some of the parameters here in terms of numbers. So this is how an IVC diameter looks like when you put it in M mode. When you take a breath, the IVC goes down, and when you exhale, it goes up. It's the opposite when you have positive pressure ventilation. There has to be a little bit of variability or very little. So depending on the variability, not just the diameter alone, you do a combination of the diameter and the variability with the breathing to determine what your potential CVP, i.e. your volume status is. And again, being an intensivist, I pay particular attention to CVP as a gauge for volume. Be very careful with that. But at least it gives you an idea of where your right heart stands. Let's see if I can show you some examples here. Again, you put your M mode, and you can see the diameter is easy to measure here, and you can see if it's much variability or not. If you see this one here, there's not much between inspiration and exhalation. This is a patient that, if you do your IVC measurement, is euvolemic, just by looking at the respiratory pattern. Okay? And look, if you have a very tiny IVC, you know you're dry, you're empty. Okay? Less than 1.5 is bad. Bigger than 2.5 centimeters, a dilated IVC. That's either a right-sided failure or an overloaded patient. And then you combine that with what they call the collapsibility index, which is the amount of time the IVC remains collapsed. If you're basically full, that IVC is not collapsing. If you're basically empty, that IVC might be so collapsed that you may not even see it. It's very hard to pick up. And anything in between. And that gives you an estimation of where your CVP is. Again, if you're very empty, the CVP is low. If you're very full and no changes with respiration, you basically have a high CVP. Okay? So again, when you have someone that is very empty, you can see barely this change. It's hard for you to determine what is what. And you can see then the amount of time the vessel remains collapsed. And then also give you an idea whether you want to give this patient fluid. This should be similar to some of those algorithms that are using pulse pressure variation of or any dynamic indicator of fluid responsiveness. This can help you too. Again, look at this IVC. Just by looking at it, it looks big. And it's not changing with breathing. Guess what? This patient is overloaded. Okay, again, pattern recognition. Smaller IVC, and you might see a hint. This is in exhalation, and then in inspiration drops a little bit. That's a euvolemic patient. This is one of my residents. You can see them. At the end of the day, they can get hypovolemic. They're dehydrated. Very interesting. So we can assess how they are. If they're working hard or not. Okay. If they're getting their bathroom breaks as well. So I think in summary, I just want you to understand that this is a powerful tool. When we're trying to measure EF, you have to understand how we're getting that measurement. If you couple that EF assessment with a volume assessment using your IVC, you get a better idea where your patient stands. You get a better idea if this patient is going to need fluid, it's going to need a diuretic, it's going to need an inotrope to get them better. Any questions? Yes?
Do you think TTE will play a bigger role in pre-op clinic, or patient care assessment?
Without a doubt. Without a doubt. And there's certain places that have an echo machine in their pre-op clinic because it's so powerful. And I'll give you an example. We had, like 3 weeks ago, we had was it a gentleman coming our way that was going to have, I'm not sure what kind of surgery it was, some abdominal procedure, elective. The medical student happened to use a stethoscope, something unheard of. He listened to the heart of the patient, had a systolic murmur. That was not reported in the pre-op. Systolic murmur. I think the gentleman was like 73 years old. Could this be aortic stenosis? Does he need to have a full workup for this? Are you willing to anesthetize this patient that has systolic murmur, is 72, and is coming for a completely elective procedure? You put the probe in, you check, the valve look good, continue. No big deal. So I do think pre-op screening could be very useful. Some programs I know have done that by having the machine in the pre-op clinic. You get a lot of echo exams, and that allows you to complete the number for certification. Okay, that's an easy one. You play with the probe, you have the patient there, you do exam, and you count that as an exam in order to get certification for surface echo. Again, type of things that you, so yes, to answer your question, yes, we should use it more often. Yes?
Just kind of along the same lines, in terms of utilizing that as a screening tool to kind of guide your further work with the consultant pre-op without doing this growing agent litigation and certifications and reliability and consistency. Utilizing your probe and saying, it used to be auscultation and patient takes an automatic hear a murmur. No big deal. Now you put a probe on it. You're relying on that person's ability to discern. I mean, where does it stop in terms of making that decision?
Listen, that's a good question because I see it in my own practice. I see my own colleagues getting nervous by, it's like, all right, I want to call this, you know, what's the liability? And I think that probably started when even anesthesiologists is doing echo intra-op, calling the shots. Well, this valve needs to be changed, or don't change the valve, or there's a paravalvular leak. You know, call your cardiologist colleagues so they can confirm this, whatever. So it's always that feeling that you can mess up when you're having a good diagnosis. I think what we're doing here is the big things, okay? I'm not asking you to measure a pressure gradient across an aortic valve. That's not your job. Your job is to, you would see that valve is sclerosed and calcific and it's bad, you will see it. Trust me, it's very easy, and I'm going to give you some examples of that this afternoon. Okay, so if the valve opens and it's clean and it's thin, trust me, that valve is fine. That may be a functional murmur, the hematocrit may be a little bit on the lower side, the patient may be a little bit hyperdynamic and empty, so bigger jets, whatever. So that is actually very relieving for an anesthesiologist to anesthetize someone that has this murmur. But I have checked that there's nothing in the aortic valve. It makes me very happy. I don't think it's going to be a liability. I think, again, as I told you at the beginning, the liability is going to be not doing the echo and then finding that the patient had aortic stenosis and you killed the patient on induction. And people are going to say, really? The medical student documented a murmur, and you guys decided to induce this patient, not even take a look with the probe? Really? So you can see how you can twist this. If you have a lawyer here, trust me, they can move it back and they can twist it in so many ways, but that's a different story. I think you have to do the right thing, okay? Which is help your patient get information. Let's say you see something you do not understand. Then you call your colleagues, call the cardiologist then. But I'm telling you, if you're seeing something you don't understand, that usually means problems. You see what I'm saying? You're ready to pick up a problem. And that's all you need. I'm not asking you to measure, you know, significant pressure gradients or to tell me that P2 is a leaflet that is prolapsing and whether this patient needs a quadrantectomy resection or just a ring, whatever. That's not your job. Okay? It's a little bit different. Any other questions?
In Florida, you have requirement that you have to use ultrasound to be paid.
To be paid for what?
Paid for like putting a center line or anything.
I think there's a cost. The good news, I don't deal with any of that thing, but I do believe that with ultrasound you get an extra, probably the Fox knows better. you get a qualifier or something, and you get more money. So even if you want to do it for money reasons, there you are. It's not my point. You see, Dr. Shah, I think, is more into the money thing, so he probably knows better. Anyhow, let's take 5 minutes, and then we'll come back and finish with the other 2 lectures.